Welcome to the Our Forever Smiles podcast, a podcast created to support mothers of children who were born with clefts and those who love them. I'm your host, Laura Arroyo. Hello, and welcome back to the Our Forever Smiles podcast. I am your host, Laura Arroyo. Thank you so much for sticking with me. We're headed towards the end of the year. We have had quite a bit of guests this year that are from the ACPA annual meeting. And so we've heard a lot from professionals and specialists and surgeons and just different people that support us along the Cleft journey, including people that are running foundations, Cleft moms that are in Cleft care now, Cleft affected individuals. So just really excited to share our final episode from the ACPA annual meeting. Again, I'm so forever indebted to Adam and Charlene, who helped me get the opportunity to record on site at the ACPA annual meeting. I was able to meet so many professionals in person, record with them, learn so much, network. I was able to get our name out there as the premier podcast for Cleft moms and Cleft parents in general, grandparents, and anyone that's supporting a Cleft affected individual or a mom who's just recently received a diagnosis or post-op care and just emotional support along the Cleft journey. So really excited. So this is our final episode from this series. It is with Nancy Rowan and Rachel Chiavatti, and they are talking about something that is really near and dear to me. When Giselle was born, she was suspected to have PRS, which is Pierre Robin sequence. And so it is something that I researched a lot whenever I was looking for, resources for Giselle in particular. And so I was excited to learn about a different method of treating Pierre Robin sequence. As we know, most of the time this is treated with jaw distraction. Well, the thought of having a jaw distraction on my little baby girl was like not the most exciting thing. So, this dynamic duo, Nancy Rowan and Rachel Chiavatti, have worked really hard with Stanford to kind of get this message out there about alternative methods for treating and caring for a child that is born with PRS. So we'll jump right in, but just thank you so much for sticking through with us during this series. It's been phenomenal to watch your feedback or to listen to your feedback. And I just really love what we've been able to learn this year. So we'll jump right in.
Thank you.
Thank you so much.
We're happy to be here.
So today we have the founders of HOAP for PRS. And so we have Nancy Rowan and Rachel Chiavatti. So what is HOAP for PRS?
So we call it HOPE. It's HOPE for PRS, and it stands for Healing with the Orthodontic Airway Plate for Pierre Robin sequence. And the way we kind of landed on that name was because the orthodontic airway plate, which we'll probably mostly call the OAP, it really brought healing to our sons and their airway diseases.
So I figured we could talk a little bit about both of your personal journeys. We'll start with you first, Rachel. So what did you learn about your son's diagnosis?
Yeah, so I had a completely normal pregnancy and normal ultrasounds, normal everything leading up to the birth. So, and a pretty normal labor and delivery. And then I remember they put him on my chest, and I kind of heard I have this, it's kind of a blur, but I have a distinct recollection of saying, oh, he's gargling a little bit, and I now think that was his tongue kind of falling backwards. But they took him over to the table and kind of checked him out, and they discovered issues with his airway. And so we figured out that he has Pierre Robin sequence, which is the small jaw, and that it happens in the womb. The small jaw develops, and that causes the tongue to develop further back, which prevents the palate from forming. And I know you've had people on before who've talked about PRS, but essentially back is best does not apply if you have PRS because the tongue falls backward and occludes the airway. So pretty much immediately they discovered the small jaw and the cleft palate and the breathing issues. So they had to put him prone and immediately whisk him off to the NICU. So I was kind of just, it was only me and my husband in the delivery room. So just me and the nurses, and my son had gone. And later on we discovered that our hospital, the main treatment that they have is jaw distraction surgery, which is essentially breaking the jaw, cutting into it, distracting it forward, and then putting in little metal plates and slowly cranking it over a period of weeks to get that space in the jaw and the airway. So it's a pretty invasive surgery. And so I was kind of just mentally preparing myself to have to face that as a parent, to watch my kid go through this. So I was Googling before and after photos of the jaw distraction surgery, and a picture came up of a Stanford article that said newborn avoids invasive jaw surgery through alternative treatment. And I was like, this is interesting. So I clicked on it. I read the article, and it's about Dr. Chu, who developed the orthodontic airway plate, which is ultimately where we ended up. But at the time, it felt like a pipe dream. I'd never heard of it before. I wasn't sure if it was a real, true option. And we were so doubtful about it, actually, that we were like, it kind of was in the back of our head, but we're like, we were waiting on surgery approval because our surgeon at Chalk checks for nerve placement and also does the surgery beforehand on a 3D model of the kid's head. So we're waiting on these things to kind of come in before we move forward with surgery. And the place that creates this 3D model of their head where they approve the surgery and practice on it and everything got hit by a hurricane. So we had this random, just miraculous window of time that we were just sitting around the NICU waiting. And I talked to my husband. I was like, why don't you just call it? Like, let's just cold call. We're not doing anything else anyway. And so we did. And she was like, send over his medical records. And we thought he would be too bad of a case, but it turns out he was a perfect candidate after looking at the medical records. We got insurance approval. We did a NICU to NICU medical flight and went up to Stanford from Chalk, which I like to say, not to brag, but his first flight was private. So, what can I say? He's a little bougie at heart. But yeah, we were 2 weeks in the Stanford NICU, got the orthodontic airway plate. His sleep study score massively improved. We were able to be discharged. We took care of him with the orthodontic plate at home until he was about 5 months old. And then he graduated from the program. And and his jaw was moved forward enough that we were able to avoid the surgery. So it is intensive on the parents, but I would do it 100 times over for the result. And so that's kind of the whole story in a nutshell.
Yeah. So going back to something you, just a little bit. So going back just a little bit, did you know what a cleft palate was before he was born?
So it's interesting that you say that because, I was whacked out on the epidural, and just kind of like first kid, completely delusional. I did tear. So she's like stitching me up. I'm like hearing cries in the distance. And then don't know who it was, but it was the liaison between Chalk and St. Joseph's where I gave birth, did come and give me every specific medical term, like cleft palate, and I am just a researcher by nature. And so even though I had just given birth and it was crazy, I Googled the 3 things like right away and then found PRO band sequence. Yeah, basically it's like, what is this? And it's a blessing and a curse. And I texted it to my husband. Like, I was like, I think this is what he has. And then of course we were in the NICU for like 30 days in that NICU. And every day they're like, have you heard of PRO band sequence? I'm like, yes, I know what it is. I Googled it 2 seconds after I gave birth, but
And she wrote it down on the PRO band sequence?
No, she just said he has a small jaw and a cleft palate and that his airway is being restricted. And I somehow had enough wherewithal to remember those 3 facts and then Googled those 3 things, and then the term PRO band sequence came up, and I was like, "Oh, this is definitely it." So
So you mentioned that you read an article and you just kind of did a cold call. So did you call the doctor's office or where was the cold call?
yeah, that's a good. So Joseph, my husband, is actually the one who made the call. I think it was to their office to Dr. Chu's assistant, is who he ended up getting in contact with. There may have been a number on the article. I'm not sure. I'd have to ask him, but yeah, he called. I think a number on the article that went to Dr. Chu's assistant, and then Dr. Chu actually reached us out to us directly after we had, which is she cares so deeply about her patients. It's been really amazing to work with her, and she really just goes out of her way to make sure that you have everything you need and to communicate just directly with parents. And in a system that can be very slow and bureaucratic, that's a very refreshing thing as a parent. So
Okay, so you said a few things that sparked a few things in my head. So what is involved in this orthodontic airway plate? And you also mentioned that Tanner, that this is a little bit of a difficult process for parents. And also, you mentioned that Tanner graduated from the program. So, what is all involved in this process?
so yeah, so the how when I say intensive on parents, it's actually I think psychologically easier because we did go through cleft palate repair, and psychologically that was much harder than anything we had to do with the OAP. It's more that how the device actually works. So it's like a little retainer. That's what it looks like. Did you
I
bring
have
Zach's?
it.
Oh, yeah, she has one of them. Yeah, it has like a little tail on the back of it, and that pushes first of all, it opens the airway, so it gets the tongue out of the airway so they can breathe through their nose. So yeah, this keeps the airway open, this little tongue part, and then then they have the nasal passage open. So essentially, that's what allows them to be able to go home from the NICU because the breathing is improved. And then the pressure of the tongue being forward stimulates the jaw growth. So it's a very narrow window in which this treatment works because it has to be um, not developed enough that it's flexible enough to grow quickly with the pressure of the tongue being forward. So it's kind of like a dual purpose, and because it does go in the mouth, like we put denture cream right here, and then you put it in and you stick it up, and then there's little pieces of tape that it connects to, and every day you take it out and clean it. So that is what is more, and you put it back in. So that's a little bit more what's more intensive on the parents. And then most people go home with an NG tube. So Tenor, he was done with his NG2 probably around 3 or 4 months. But if it comes out, Stanford actually trained us on how to put it in and to put it back in and everything. So it in that way, the taking it out, cleaning it, putting it back in, and learning how to do the NG tube. Those are the 2 ways in which it's a little bit more intensive on parents. Yeah.
And you mentioned graduation. So, how old are babies usually when they graduate from the program?
Oh yeah, so there are progress photos. So we get out of the NICU, and then once a month we go up to Stanford and see Dr. Chu, and she measures the growth of the jaw. She looks at pictures and then also looks at the alignment of the top and bottom teeth, and then she determines when the jaw has grown far enough that we can take the OAP out, and then it's stamped by a sleep study, and that's the sleep study is the markers of like, okay, you're good to go, like your breathing is adequate. So yeah. No, there's like a 6 month window. So he graduated at about 5 months, and then we got our repair at a year.
So, there's also a sleep study that happens.
There's this sleep study, yeah, 2. So there was one that happened. There's one that happened with the OAP in before we took it out. There was one that happened after the OAP was out before cleft palate, and then there was one after cleft palate repair.
That is so incredibly insightful. Nancy, I would love to hear your story about your son as well and how you came to creating or being one of the founders of hope for PRS?
Sure. So Zachary he's my third child, and same thing as Rachel. Pregnancy went fine, delivery was fine, nothing too crazy there. But when he came out and they put him up on my chest, he was pretty purple. And they were rubbing him, and he was on my chest for maybe 30 seconds or so, and he wasn't crying. So they weren't, at least to me, they didn't seem super nervous, but they said, let's just take him over to the table, warm him up, we'll work on him. And he still wasn't crying. It was kind of like a weird, similar, like a gurgling sound. And pretty quickly, the NICU team rushed in. A lot of that is such a blur for me too, because I was getting taken care of. I could see his chest rising and falling some. So I knew he was alive, but obviously in distress. They quickly got him on CPAP and they took him up to the NICU. And our hospital in Columbus, Ohio was great about sending someone down consistently to update me as I was in recovery. I went through hemorrhaging. So getting myself to a point where I could go to the NICU safely to be with him. Um, but they were great. They always had someone like a liaison coming from the NICU down and telling me, here's how he's doing. We're already able to drop like the oxygen that we're giving him. By the end of the night, he was on just room air. They were able to take him off the CPAP. But during the time where I was getting prepped to go to the NICU, they did come down and say that he had cleft palate. I wasn't super surprised by that because I myself was born with cleft palate. So it was something that during each of my pregnancies, we went to maternal fetal medicine and we said, can you just check to see if you can see it? It's really hard to see a cleft palate on ultrasound. And so for all three of my kids, they said, no, we don't see anything. Obviously, we won't know till birth. So I wasn't super surprised by that, just mostly concerned about his airway and why wasn't he breathing right. But like I said, by the time a lot of things had transpired, we got up to the NICU. He was on CPAP, but by the end of the night, he was completely off and just on room air. But they did keep mentioning that he had a small chin. And I'm like, okay, well, what does that even mean? I stayed off of Google for the first couple days because I was just trying to rely on the clinicians there to tell me what I needed to know. So a few days went by. He still, at that point, had not been transferred to the children's hospital. He was being taken care of by a level 3 NICU in our adult hospital. And once we got him transferred to Nationwide Children's, that's when we received the Pierre Robin diagnosis. A lot of people were coming in. It was certainly overwhelming. We often say it felt like we were drinking from a fire hose because it was just person after person coming in trying to give us more and more information about our son, which we were so grateful for, but it was also hard to process at the same time. I remember a plastic surgeon had come in and he told us that our son was going to need jaw distraction. And I'm also a researcher. So that point, I turned to Google and I wanted to learn all that I could about this surgery that my son needed to have. I was shocked when I was looking at these images of what he was going to go through. I turned to Facebook support groups just to see the experience that other people had walked through that I was about to experience myself. And something just didn't sit right with me. This was September of 2022. And I thought, certainly by now, there's got to be a better way. And what we were looking for is something non surgical to help him because he was in the NICU. He was actually on his back, breathing just fine. He had no oxygen. He was not desatting at all. And he was getting to the point where he was taking full bottles by mouth. So he himself was handling it very well, but then I had a doctor telling me that we needed to have this surgery done. So that obviously sent me back to the internet. And I remember one night sitting on the couch and I typed in non-invasive treatment to Pierre Robin sequence. And that's when Dr. Chu's article started coming up for me. And I looked at my husband and said, I don't know how we're going to do it, but we have to get to Stanford. Um, So at 3.5 weeks, Zachary ended up getting discharged from the NICU. They deemed him safe to come home. He was on a pulse ox monitor at night, just I think a lot for our reassurance that he was okay. Like I said before, he wasn't having any DSATs in the NICU, but they still wanted him to go home on that. And then at home, feeding became more difficult. He wasn't taking full bottles anymore. Through our follow up visits the next week and a half, we were noticing that he wasn't gaining weight. It was harder to keep him awake through the feeds. And so we kind of all knew something was happening. He had a repeat sleep study at this point. He had one while he was in the NICU, and he had obstructive sleep apnea, but it wasn't to the point of being super severe. So once we're home, we had another sleep study, and at that point it was severe. And so the doctor said he needs surgery. We kind of knew that was coming. So we also had done a call to Stanford, and we started getting the paperwork moving so that we could fly out there. And we jumped on a Southwest flight with our son and took him to Stanford. And much the same happened. Once we got there, he had a mold done the first day being in the NICU just of his jaw so that Dr. Chu could create the orthodontic airway plate. It was placed the next day. He had a sleep study the following week, and that determined that he was on a good path to recovery. And then the week after that, he went home. So he was also in the NICU at Stanford for about 2 weeks.
We were in the NICU at the same time.
We were.
That's how we met.
Yeah.
Yeah.
Mhm. Our beds were side by side, actually.
Yeah.
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 Were there other families there with you all, or you were at Stanford?
We both just happened to be there at the same time. I think they were like the 22nd, 23rd babies to have had it, but we just happened to be there at the same time for treatment. And it was like a shared NICU room. So it's kind of easy to tell, like, we're both here for the same thing. I mean, they don't disclose it, but we have eyes. So.
Yeah. There weren't any other babies that had this device or the taping across their forehead. So we knew. And so we started talking and having lunch. Yeah. So it was great. It was nice to have someone to go through that experience with. And then even once we got home, we would text each other like, hey, how's Tenor doing with this? Or how's Zach doing with that? And even on our follow-up appointments where we would all kind of meet back, we'd go have ice cream together and get the boys together. It was fun.
Oh, that's really special. So I actually have a question for you, Nancy, about your own diagnosis. What did your parents or your family share with you about your own cleft palate journey?
No, I mean, I had the cleft palate. It was repaired when I was around a year old. I know that I had speech therapy when I was younger, but other than that, there's been no other impact on my life.
Wow.
So they didn't pursue any type of extra testing. It was just kind of something I was born with, and it was a possibility we knew for possibly our kids. But yeah.
I'm sure you had the surgery when you were young. Yeah, are you impacted at all by your cleft palate now? So when did this idea of hope for PRS come about for you?
I mean, it kind of came up while we were still in the NICU because we just felt so safe and cared for at Stanford, being in Dr. Chu's care. We knew that she had our son's best interest at heart. She was working tirelessly for them, and not just to make sure that the OAP was working, but she wanted us to go home. She wanted our families to reunite. My older kids hadn't seen Zach very much of his life because he was in the hospital, and this was at the tail end of COVID, and they weren't allowed to come in the NICU at this point. So emotionally, it was a struggle for them too. But we love that her desire was to get our families back together, get us home where real healing was going to happen. And we were just super passionate about making sure that it wasn't just our babies that she was able to help. We wanted acts, and we still do. We want every PRS baby to have this option. Whether or not they're able to do it, that's another question, but we at least want this to be brought to the table when a clinician walks in the room and says, your child has PRO band sequence, their airway's obstructing, and here are your choices.
So, Rachel, you mentioned that Tanner was a good candidate for the airway plate. So, what makes a patient a good candidate for it?
So that is a Dr. Chu question. I'm like, let me look at the analysis. No, but yeah, she reviews. If you when you send the medical records to her, she's the one that reviews it and looks. I'm guessing at like the sleep score, the measurement of the jaw, the CT scan. We had gotten all those things done by that point. So those are the items that we sent to her to evaluate to determine, okay, based on, and I think she did look at his actual CT scans and like the measurements and everything to see, okay, is this device going to be, something that could work for him? So, yeah, those are the things that she looks at. And like Nancy was saying, we just we want to be a resource for people if they find themselves in the NICU like we did and they're looking for, information, that if they can't find it at the hospital, we can at least open the door, introduce them to Dr. Chu. If anybody reaches out to us on our website, we can answer any questions that they have about it. And then ultimately, whether jaw distraction or OAP is right for the patient is really up to them and their family and what they feel is right. But we're just more passionate that they're given all the information and the option to make an informed decision. So
Is this device only offered at Stanford?
Seattle Children's is also doing it for in-state patients. At Stanford, they're able to accept patients from all across the U.S.
So, you'd be surprised they actually don't do jaw distraction in Australia. And so I'm so intrigued by this device because I feel like it's going to be a game changer. So, for both of you, what have you learned about, or what has been your biggest lesson learned in navigating this journey or being a part of such like a major innovation in this space?
oh wow.
Yeah, there's a lot of countries that's not their first line of defense. I gotta think on this.
Something did pop to my head, so
Okay.
while you're thinking, I'll answer. And that is just the first thing when you said, like, what's the biggest lesson that you learned? Is just like to not be afraid to ask questions. I think, you know, I do think that doctors have a lot of authority and we should listen to them. However, it's okay to ask questions. It's okay to do your own research. It's okay to like, um, to examine everything from all sides and then make a decision. Yeah, I think that's, as somebody who is not very combative by nature, through this process, I had to really work that muscle in advocating for my son to, when I felt like it was right, push back, even though it's extremely uncomfortable for me and my personality type. And so that is an area to the point where I'm like, pushing just on random people that I'm running into. I'm like, wait, I have to turn it off. I don't need to use this all the time. But it was a good skill to develop. And now I'm reining it back in. But I can see that.
I would say I've definitely learned, like, similarly, trust your mom gut. I think we have that within us, and we we need. It's okay to listen to that. Um, if something doesn't feel right, then do your research. Even if you're not a medical professional, like, still spend time researching and look at both sides. Like she said, ask a lot of questions. And at the end of the day, make the decision that you feel is best for your child and for your family.
I love that. So, what do you hope for?
What do we hope for PRS? I think just that we want to make sure that people know that we're there, and that's why this is going to be, I think, such a really valuable thing for us. Just that because it is hard to detect on the ultrasound, and most people don't know, unless they've maybe had another kid with it, they don't know, what's coming for them. And so you're in the NICU and you're kind of disoriented and you're cloudy, and we just want it to be easier than it was for us to access all the information. So I think if Hope for PRS can help it so that anybody throughout the US, when they have this diagnosis, they have access to all the information just immediately, I think that would be a really great goal.
Yeah.
What about you?
I mean, I hope that we're able to form just a community of supporters of one another, because this is something unlike anyone else I know, except for my OAP friends, have ever walked through before. And so only Rachel understands what it's like to have the NG tube come out in the middle of the night, and you just have to put it back in because this is part of your son's treatment, or what it's like to fly across the country. And so I just want other moms who are going through the Pieroban diagnosis to feel supported, to feel seen, and to have someone there who truly understands what they're going through.
And Nancy is the best at that. She's like the mom of all the OAP moms.
I absolutely love that. I think that I've always wanted to provide different resources and alternatives to our parents and listeners. And I think that this is going to be a complete game changer. Me, as a mom who was concerned about PRS and particularly concerned about jaw distraction, we want to make sure that this research and this method is out there so that parents know that they do have options, and so that their fears can kind of be minimized in that, especially in the United States where, this is kind of the jaw distraction is kind of like the recommended treatment method. And so just thank you so much for being on, for sharing about Hope for PRS, and anything that we can do to support you all in this journey. Please let us know.
Thank you so much for having us. Yeah.
And thank you all for listening to the Our Forever Smiles podcast. Be sure to rate and subscribe wherever you listen to podcasts. I hope that you have enjoyed this audio experience. Maybe you cried a little, laughed a little, but more importantly, I hope that you feel a little piece of reassurance and even joy in your journey. Talk to you next week.